Hello, I'm Matthew Gavidia. Today in the MGH Life Sciences and Medical World News, the American Journal of Managed Care is pleased to welcome Dr. Jenifer Leaf Jaeger, Senior Medical Director at HealthEC. Can you just introduce yourself and tell us a little bit about your work?
Yes, hi. So my name is Jenifer. I'm a physician trained in pediatric infectious diseases and pediatric urgent care. Prior to joining HealthEC, I was the interim medical director for about a year, followed by the director of the Infectious Disease Bureau and director of population health for the Boston Public Health Commission, which is the Boston City Health Department. Prior to that, I have worked with CDC as an epidemic intelligence service officer, working on H1N1, with the first few US cases, and also worked on Ebola preparedness for New York City Health Department.
And to get us started off, can you discuss what you saw with oncology patients during the early days of the COVID-19 pandemic? What were you hearing from peers, customers, and the industry as a whole?
Sure. Of course, now being in population health and on the IT end, I'm not seeing any patients directly, but we work very closely with our clients, many who are direct providers, and certainly are talking to folks since then to see what they're seeing, and of course scouring the literature to make sure that you're up on what's going on. And of course, in the very, very beginning, what we knew really came out of China, and the percentage of oncology patients who were infected with COVID was relatively small, and so the data weren't as robust, but it was certainly concerning, suggesting that folks who are immune compromised would have a much more severe course with COVID. And that makes sense. You know, as an infectious disease doctor, most folks who have an impaired immune response, whether it's cellular or antibody, we have a difficult time handling infections of all sorts, particularly viruses. And so we were particularly concerned that we make sure that we could identify among that population, risk stratify those who are at highest risk for having severe infection. So certainly anybody with cancer would be at highest risk. But if you're talking to a large multi-state oncology practice that has nearly 100,000 oncology patients, to say everybody's at risk doesn't allow them to risk stratify at all. So we really had to dig in deep and take a look at how else to risk stratify that population. But the literature, to answer you, the question is, what were we seeing initially? Much higher levels of folks who were having severe infection or those folks dying of COVID. And then it seemed that it decreased over time. And when you look at populations that are stratified just by, let's say, immune compromise, that includes folks who have cancer, those who have had solid organ transplants, HIV, or folks who are on immunomodulatory therapy for autoimmune diseases. And those are very different populations. And so sometimes it's difficult to understand exactly what we're seeing. Right now, it does appear that individuals who have cancer, depending on what type of cancer, might have a more severe infection, but depending on the type of cancer and maybe what type of therapy they're receiving, it may be that the increased risk isn't as great. So fortunately, a lot more data needs to be collected for us to make any definitive statements.
What was HealthEC's initial reaction and action to support your oncology practice and medical group customers? And additionally, can you give one example from one of your customer sites?
What we do in HealthEC is twofold. One is data analytics, where we're using our ability to use prospective risk scoring and modeling, as well as machine learning and AI, to collect data and analyze it and crunch it and hopefully make something impactful come from that. The other part of it is care management. And so taking those data and actually developing a program that allow us to support care managers or nurse practitioners or even community health workers in the field with all the various assessments that need to go on, in addition to actual medical care. And here we talk about access to care, social determinants of health, and a variety of other issues. And so part of our focus was actually on both of these areas. From a standpoint of the very first thing that we did, like within the first few weeks of of seeing what was happening in the United States, we were able to develop a COVID program, sort of soup to nuts. And the first was developing an algorithm that would accurately predict those at highest risk for severe disease. The program that we designed actually took into account numerous factors, including what was published through CDC and WHO and the experience in China, as well as public health officials on the ground within numerous countries, including China, Germany, Italy, who were seeing a number of these cases early on, as well as doing risk analytics and using predictive risk modeling based on the type of inpatient. So, for instance, with oncology patients, we would use C3, which is the cancer comorbidity index. We had either Johns Hopkins that was looking at the privately insured or ACO group, and then of course HCC looking at Medicare populations, and they're very different. In fact, there's an article I'll refer to later that actually looked at risk with COVID and treatments in either the insured, privately insured, or the Medicare Advantage group, and they had different effects. But not even knowing that, we were looking at the very beginning, looking at this as well as the history of utilization and cost, and throwing in a number of different factors, and able to generate a list for all of our clients within the first few weeks of those at highest risk, either 10%, or if that was still too large a number, for an individual practice to reach out to effectively within the first week or so. And that was our goal, was how many people could they reach, or could they reach an entire, the highest risk population within that first week, and assess where they were. If it's going to take you a month to reach them, that's not okay. So in certain cases, we needed to break it down to about the top 1%. And we were able to actually effectively do that. One of our clients that has nearly 100,000 oncology patients in several different states, a couple dozen practices, independently evaluated our risk and our risk group, and found that it correlated very well with their own group. And in addition, we identified an additional 25% of patients that they hadn't specifically identified, and found that in fact these were the people that had already been suffering or were at highest risk, and were able to then identify their additional needs, who needed to come in from a cancer treatment standpoint, who was well enough that they could stay home and avoid exposure, and then assess from there. And that's where the care management part of this comes in, was the impacts of social isolation are numerous, including impaired access to care. So are they getting their medications? Are they getting nutrition? Are they getting social support? So being isolated means there's increased risk of depression, and fall risk and pain is increased when you're depressed, associated with chronic conditions and cancer. And so there are a number of issues where not having the ability to lay eyes on routine care, or your family isn't able to lay eyes on their parent or grandparent, or increases the risk that there are problems on the line that aren't being identified. And so our intent was who could be managed successfully and safely through telemedicine, and then who actually needed to be brought in. And that was our goal. And the feedback that we're receiving from our clients is that that's been very effective.
And you kind of just alluded to this, but what role do social determinants of health play in cancer care with and without COVID-19?
Quite a bit. and even more so during a pandemic with so many unknowns, and where never before have we had so many people isolated. And again, out of sight can't be out of mind in this particular case. So the first that I mentioned is just basic access. Do they have access to adequate nutrition, to their medications, whether that's for cancer or for anything else, diabetes or anemia, or really anything else? What are their transportation risks? A lot of folks are not going to take, and particularly those who are immune compromised, were suggested not to take public transportation. And if that's your only way of getting around, then how are you able to make your appointments if in fact you need to be seen. And so the impact on this group, particularly those who are elderly and more infirmed and for whom transport is difficult anyway. A lot of folks would be calling Ubers or private cabs and didn't want to do that either. So I think that's probably one of the most important things that we learned, was that the access in this case was critical. And the digital divide at this point becomes also important. We know that about 85%, maybe even more, 95% of folks have cell phones, and maybe 75 to 85% have smartphones. But when you're looking at the elderly and low SES populations, more urban populations, some of these folks do not have smartphones and don't spend time using Zoom like we are now. And so the impact of social isolation at that point becomes critical, because you're not even able to lay eyes on your patients. The next is looking, again, as I mentioned, the unintended consequences of the social distancing, meaning depression and risks of fall and pain. These other assessments need to be made through, again, telehealth. The other is really taking a look at the, in addition to the care for COVID. So if are they critically ill and they need to be seen, when it comes to the oncology population, elective doesn't mean non-urgent. So staging still needs to go on. MRIs still need to happen. Biopsies still need to happen. And your infusions still need to happen. Some of these they're not heart attack level or accident level that somebody says, okay, this is an urgent, this is an emergent issue, but these are critical nonetheless. And some of the deferred care, we're going to need to wait, a couple of years down the line, maybe, to see what the impacts are from that standpoint.